Assalamu alaikum. Hello, everyone. Welcome to Simman Stations. In the beginning, let me introduce myself. I'm Basant. I'm one of the doctors working in UK. I am neonatal life support instructor in European Resuscitation Council. And I have done my PLAB 2 around 2.5 years ago. I passed 15 stations out of 16. I provide PLAB 2 courses since 2 years. And today we gonna talk about simman. Do you hear me well? Yes, okay. And you see my screen?
I'm sorry, if you could raise your voice just a little bit, that would be great.
Okay. Do you see my screen? Amazing. Okay. So in the beginning, I know simman is a bit tricky, a bit challenging, and I don't believe anyone who say no, it's not. Anyone who tell you simman is an easy station, he's a liar. Okay, don't believe that. I know it's challenging because it's so hard to handle with the mannequin. And some people find it confusing if just dealing with a sound and like a mannequin there, not moving, not opening mouth, and a bit challenging because it's acute and well, and you need to act fast, and you need to be correct. In 6 minutes, you need to reach diagnosis. And actually, it's so horrible, especially if the simman dies. You'll be in a very like unwell situation. Okay, so it's not an easy, but the thing that you need to keep in your mind, 99% you will find simman station in your exam. And if I'm talking about simman stations, there are till now 18 stations. Okay, so if you think about it, you might study like in obstetric and gynae around 50 stations, 60 stations, and you might go to the exam, find none of them in the exam, isn't it? So can you imagine 18 stations, you will get one of it in the exam. It deserves that you study well in this exam, in simman station. You should not ignore simman. Some people go to the exam without studying simman because it's a bit tricky, it's a bit challenging. Yeah, it's challenging, but you will find one in your exam. At any station, you will find one. So please don't miss simman in your exam, okay? Okay, so what we gonna do in the course, this is the first session of the course. So the first day, which is today, what we're gonna do, we'll talk about simman and how you will be assessed. One of the most important thing you should keep in mind, how I will be assessed in this exam. A lot of people go to courses, go to academies, and they don't know how they will be assessed, what needed from them. So we will talk about that in a while. How many stations you have? 18 stations, and we'll talk about that. What is the approach? And the approach is A, B, C, D, E, I SPAR. We will talk about everything in details. I know some of you are not medical, like some of you are like working in as a clinician. Some of you are radiologist, pathologist. Some of you out of the medical field for a while. So I will talk from the basics. Like if you forget everything, and we will start from the beginning. So of course, we will do practice on everything, on A and B and C. In everything, we will do practice. So in day 2, which is tomorrow, it will be also 8 p.m. We will do revision in day 1. If anything left, we will continue. We'll talk about most common mistakes in simman, we will discuss asthma station, COPD, anaphylaxis, pulmonary embolism, and we'll do practice in each station. In day 3, we will discuss pneumonia, urosepsis, angina, heart failure, atrial fibrillation, rheumatic fever, upper GI bleeding, perirectal bleeding, postpartum hemorrhage, and also we'll do practice on each station. In day 4, we will revise again hypoglycemia stations, post-cesarean pain, acute limb ischemia, morphine toxicity, and do practice. And day 5, revision. And of course, in every day, we will do, I will answer your questions. So let's talk again about what are the stations, because I need you to study simman in this order: asthma, COPD, anaphylaxis, pulmonary embolism. Why I put all together? These 4 should be together. Why? Because all of them are P part affected. So if you are studying P part, or you are gonna focus on P part, you need to take all the station in. You will have problem in P part. If you are gonna pneumonia and urosepsis, it's sepsis station, angina, heart failure, atrial fibrillation, rheumatic fever, all heart problem, all C part, postpartum bleeding, upper GI bleeding, perirectal bleeding, all the same approach. Hypoglycemia, post-cesarean pain, acute limb ischemia, morphine, all in D and E part. So I need you to study in this order, okay? And we will take it in the course in this order. Okay. Let's come back to the simman. Okay, so one of the most important thing you need to keep in mind that, and a lot of questions came to me about that. It's a simman, it's a practical part. Is that important to take an online course for that? And this is a very good question and understandable. But I want you to imagine you, like a surgeon, you go for an operation and you don't know the anatomy. You can't do it. So I can't say it's the only thing, but if you have the knowledge in your mind, it will be much easier to do. Like doctors will say to you, ABCDE in the academies, for example, and you don't know exactly what you should do. What is the most important thing? What is the clue? If the patient is not talking hypoglycemia, what you will do? If you found rash, what you will do? There are specific things. You need it to be easy for you. Okay. So in the beginning, if you are out of the station, how to know that you are gonna deal with simman? How you will know this is a simman station? First of all, it's a high fidelity mannequin. It will be written outside in the stem. And of course, when you enter the room, you'll find the simman. I want you to watch something, because a lot of people go to the simman. Give me a second. This one. A lot of people go to the simman station.
With Adobe Express, creating everything we need to share a home fragrance business is easy.
A lot of people go to the simman
Now, every day can be a little
knowing how it looks like. This is the simman, how it looks like, okay? It's a bit larger than the... can you see the video? Can you write in the chat? You see the video? Yeah, okay, amazing. So this is the simman. It's a bit bigger than the human being size. And it started blinking. One of the candidates told me when the simman started blinking, I fall down because I got scared. So if you know how the simman looks like, you will not be scared in the exam. And unfortunately, there is no simman station, real simman in the academies. So you need to Google it. You need to see in the YouTube how the simman looks like, okay? So So it's very expensive, by the way, but you can feel the pulses on simman, okay? And the simman will be attached to the monitor. Of course, you will not do that on the simman because it's very expensive and they will not ruin it. They show you the structure and they can control everything. The simman can blink, and when you shine light, the pupil constrict. So they can control everything. So in case of morphine toxicity, you will see a constricted pupil. You can appreciate it by yourself. Here you can see a swelling of the lips and tongue. Okay. This is the first one. So I want you from this video to get the idea that what will be the simman look like. That you can hear by stethoscope the heart sound of the simman. You can hear by yourself the chest, the air entry. You can see the constriction of the pupils. You can feel the pulses. You can feel everything on the simman, because in the academy it was one of my mistakes and it was one of my surprise in the exam. That when I went there, I was expecting, like I was in one of the academies, and when I put the stethoscope on the simman, they used to tell me wheezes. And I was expecting the same. I was surprised in the exam that I can hear the thing on the mannequin. So I was waiting for, is that, like, I looked to the examiner, can you tell me what is that? What is that sound? Because I don't know that I should hear from the simman itself. So this is one of the most important things you should keep in mind, okay? And if you are expecting this, it will be much easier on you to face the exam, okay?
Medical weight loss is not
also.
cheating.
Sorry,
It's actually the smartest way to lose weight. For decades, you've been told that losing...
Can you see this one? This is the female simman. And this is the hair look like. It looks horrible in the exam. If you don't know that you will face something like this, you will be surprised. You will take time to absorb the shock, okay? It's horrible. It's so big. The hair is like, what the hell is this? So, and then you enter the room, there is a speaker, and in the speaker, the simman is talking. So it will not move the lips to talk, but you will hear a hearing system, a speaker system. So you will hear the thing. This is the point. So it's scary. You need to expect what you're gonna see. This is what I want. And this video I will put to you on the group. I don't know if you have the group. I will share, because some people know. So I'll share the group on the chat. So if you are not there, please join the group. Let me put it in the... So I will put the videos that I will share with you today on the group. Fine. So this is the first thing. I need you to imagine how the simman will look like, okay? This is the high fidelity mannequin. There is a question always that will be someone there in the room. So who will be there in the room? You will find the mannequin. You will find the examiner on the corner on a desk. And before, there was a nurse in some station in the room, okay? Nowadays, they are not bringing a nurse. just you, mannequin examiner. If a nurse is there, we will talk about that and how you will deal the station, okay? Usually the nurse will be there if the patient is not stroking, but now it's not the case. Recently, it's not the case. So again, 18 station, there is a question. Any high yield, what I mean by high yield, is there any specific stations that come more frequently to the exam more than another one? No, there is no station coming more than another one. I can't say study this, and ignore this as this is in simman, because it's 18 stations and you'll find one, what you want. This is super easy chapter. If you miss it, you are missing a lot, okay? And the simman is the lowest score in the exam. So if you get 12 out of 12 in this station, you will get high score in this one, which other people will not get. So you need to focus on this. And the most important thing, how will you be assessed? Like any other station, there are 3 categories: data gathering, IPS, and management. First of all, when do you think you can take history from the patient? In which point, like in the beginning, in the A part, in the B part, in the C part, after ABCDE, when you can take it? What do you think? In the beginning, whenever he is stable. If patient is stable, then in the beginning, if the patient is stable. Yes, if the patient is able to talk, if the patient is stable, and if the patient can be able to talk, by the way, but he might be struggling, like for example, doctor, he can't talk very, like he is not comfortable. So please, if the patient is not comfortable, ignore the data gathering now, make the patient comfortable to talk, and then take history. Okay, so IPS. I know like by heart how hard and stressful the exam is. And I know how horrible and stressful is the simman station is, okay? But you need to know how you will be assessed. If you ignore the IPS, you are ignoring 4 marks. 4 marks data gathering, 4 marks IPS, 4 marks management. This is 12. So if you are ignoring IPS, you are ignoring 4 marks. So as I always said, please like prepare your mind to deal with this stress and giving good IPS. For example, I enter the room and I found my patient while I'm talking. Patient is struggling with breathing. I can see you're struggling with breathing. I entered the room, I found that the patient is in pain. I can see you're in pain. So in some stations, the patient will be unconscious, and then you treat the patient well, hopefully. And then the patient start to talk and asking you what happened. A lot of candidates, what they do, they will not answer. They will ignore the patient, and they will tell the patient, for example, I've seen a lot. They will tell the patient, okay, can you bear with me? No. What happened? You were unconscious and you found your blood glucose is low, so that we give you glucose, and I'm happy that you are talking to me now. So if the patient is struggling with breathing, I can see you're struggling with breathing, I will give you oxygen to help you with that. So explain to the patient, okay? Every now and then, ask the patient, how are you doing now? How are you feeling now? Okay? So IPS is important, and it's kind of mind training, like you will prepare your mind to do that. Like one of the preparation of the exam is to prepare yourself how to manage stress, how to calm down yourself, to put yourself in different situations so that you can face stress while practicing, like in mocks and in face-to-face stations, in the online mocks, in the face-to-face mocks. So you will face this stress and adrenaline in the exam. You'll feel much better, okay? The last 4 marks is for management of the case. And one of the most important thing I need you to remember, that if you ignored or like miss to manage the case in the first 6 minutes, you will not get 2 in the management. Even 2, like they can give you 1, but not 2. Sometimes if the examiner is so kind, can give you 2. Why? Can you imagine? Can you put yourself in the examiner place? And you find a lot of candidates coming, and some of them will manage to treat this patient in 6 minutes and make the patient stable, and some will just verbalize at 2 minutes remaining. How will you evaluate? They are not equal, isn't it? Because if this is acute and well and you are not quick enough, so you're not managing, so you are not competent. So put yourself in the examiner place. If you are not managing, I'm not talking by myself, I'm talking regarding the results that I've been noticing for the last 2 years. So don't expect to get good marks if you are not managing the patient in 2 minutes. I've seen a lot who say the management, full management in the ice bar at last 2 minutes, but they didn't do in the patient. They never get more than 2, never. And I've seen a lot that at 2 minutes remaining, they didn't do like uterine massage or give like initial, like very, very initial and first aid steps. The patient keep deteriorating and the alarm of the monitor keep making sounds. At 2 minutes remaining, they become more confused. They don't know what to do because they are handing over and the patient is deteriorating in a very horrible situation, okay? So please make sure you are quick enough. You talk about management in the first 6 minutes, okay? Okay. How to approach simman stations? First of all, your mindset. Again, if you are going to the exam with the mindset that I will not make it. I remember one of the candidates, I had a face-to-face lecture in the academy. So one of these candidates, after doing this, I explained everything, and he came out to practice one of the station, and it was face-to-face, and I know it's a bit stressful. He didn't do very well. At the end, he told me something. I was about to get heart attack because of it, because I spent a lot of time explaining. And he said, I know simman station is not one of my stations. So I told him, why you are attending if this is your mindset? Why you are practicing if this is your mindset? Why you are wasting your time? If you are going to the exam with this mindset, you will not make it. So please, but I can do it. And a lot of candidates get 11 and 12 out of 12 of this exam, of this station. And it's very, very easy if you know how to deal with it, okay? I'm a neonatal life support instructor, and I examine candidates to give them the certificate for neonatal life support, for example. So I've seen a lot, and I see if you are following a specific approach, you will make it, okay? So first of all, your mindset, please go to the exam and you consider this station, I will make it. I know how it looks like. I know the most common mistake. I know the approach. I know each station. What you need more? So you just need practice, and we will do it in the course, okay? Second thing is the most common mistakes. Why it's important? I will talk about that tomorrow in day 2 in the course. Why it's important? Because as I told you, if you are not expecting that, for example, the simman is blinking, you will fall down, and he by the way fall down the tray with the content of the tray. It was a horrible one, okay? And if you don't know what is the most common mistakes, like for example, I will tell you, one of the most common mistake is how to deal with the tray, with the drawers, how to manage it. If you are not, if you don't know that there is a problem in this point, you will not make it. If you put in your mind, for example, the examiner will talk to you and tell you like assume done, or give you numbers of something, or like result of something. If you are expecting this is mistakes. This is common mistakes, that you are expecting something from the examiner. If you don't know that, you in the exam be confused. Why is this examiner not answering me? And you will become confused, and this will affect you. One of the most common mistakes is you uncover the patient without telling the patient that you will uncover him. It happened with one of the candidates, and the role player or the simman become very angry and told them, "What are you doing, doctor? How can you uncover me?" So please, most common mistakes is important, because if you are expecting, you will avoid. And we will say like how to deal with the drawers, how to deal if the simman get angry, how to deal if the simman arrested, how to deal with every situation, okay? So most common mistakes is important. In the STEM, how to approach a simman regarding the STEM? First of all, high fidelity mannequin, and they will tell you, verbalize everything you're gonna do. They want to know what you are thinking about. If you are in emergency situation as an F2, what you gonna do? So I need you to focus on 4 things. Where are you? This is high fidelity mannequin, so you know it's a simman. Name and age of the patient, and am I gonna to talk to the examiner or not? Okay. First of all, where are you, and why it's important? Where are you is important because sometimes you will be in E&E. So if you're gonna say, I will admit the patient, it makes sense. If the patient is already admitted and you are saying, I will admit the patient, doesn't make any sense. You don't know where you are. So know where you are, so you know what to say, okay? And also where you are, why? Because if I'm gonna say, I will involve the obstetric team, and you are in obstetric department, it's a shame, okay? You need to focus. And name and age of the patient. Why it's important? Because at 2 minutes remaining, for 2 reasons. In the beginning, if you are, while you are confirming the patient identity, you need to remember what is the name and what is the age, or like a date of birth. It could be, sorry, let me correct this. Because if you have date of birth, you need to confirm the date of birth. If you have age, you need to know the age. And am I going to talk to the examiner? Because at 2 minutes remaining, some people get confused. Am I going to talk to the examiner or not? And they stop for a while and don't know what to do. Be focused. Am I going to talk to the examiner? Again, where I am, name and age of the patient. Am I going to talk to the examiner or not? Because you can continue your station with the mannequin, with the simman. So you don't need to talk to the examiner. Not a must. You got me. It's not a must to talk to the examiner in each station. It depends. For example, in pneumonia station, you don't have to talk to the examiner. So it will not be written, and the examiner will not tell you talk to me, and you need to explain everything to the simman as a patient, okay? So when you enter the room, like approaching the simman while entering the room, you need to knock the door, please. And please, if you are getting out of the room, close the door after you, okay? And please, when you enter, you will say your name and your GMC number. It's a must in each station. So when you go in every station, in any station in Plateau, you will knock the door, my name, my GMC number. And one of the most important thing you need to keep it in your mind is to look around. This is the point. This is the time that you need to look around. Why? Because some of you with the stress, go to the station and it will be video station. Like you will see a video, but sometimes the room is small. I agree. But there is a video and it's very big video, a screen, and some of you will deal with it as a telephone call because they didn't notice this is a video. And the role player will be on the screen and you will not notice because you are not looking around. So while you are saying your name and your GMC number, please look around. See what are you facing? Maybe you find a mannequin. Maybe you find a simman. And while you are finding simman, you can find inhaler besides the patient, a catheter coming out, blood transfused, a lot of things you can notice. So while saying your name and GMC number for any station in Plateau, please look around. See what is in the room. By the way, the examiner will be focusing on revising that you are the right candidate. So no one is looking at you. So just look around, okay? So you knock the door. You will say my name is, my GMC number is, and then I can see my patient is attached to the monitor. Why I'm going to say that? Because they will tell you, verbalize everything. So at that point, I'm saying I can see this is a step was taken, okay? And I assume I've taken all universal precaution. Why? Especially in E&E. If you are going to an unwell patient, I need you to remember that in E&E, you need to take your precautions like a mask, gloves, apron. So how to make it in one sentence? I assume I've taken all universal precaution. Again, knock the door, my name, my GMC number while I'm looking around. I can see my patient is attached to the monitor. I assume I've taken all universal precautions. That's it. Don't say mask, gloves, apron. Just say I've taken all universal precaution. There is a lot of dilemma and a lot of question coming to me about, should I say this sentence? Is that will I sound scripted? So I know this is in your mind, but because you need to. In some academies will tell you, don't assume anything, just go and do it. There is no apron in the exam. There is no gloves, there is no mask. So from where you will get it? But you need to consider it. I never go to any patient in the hospital without wearing a glove. So you need to wear your gloves while you are going, but there is no gloves, so you can verbalize it and don't worry about it. There is another question. So I know your question that will come to your mind. I will answer it before asking, okay? And you will be surprised. So another question come to me. What if I forgot to say these words? Like I forgot, I can see my patient as attached. What if I forget that? I assume I've taken all universal precaution. It's not a must to say, okay? If you forget it, leave it. Because sometimes you'll find very weird and very strange if you are just dealing with a patient now and then I see you see, I assume I've taken all universal precaution. If you forget it, okay, fine. In some point, I will tell you, if you forget it, come back to it. But if you forget it, okay, you can, in the middle, you can say, I can see my patients attached to the monitor, like in for example, in B part. But if you forget, I've taken all universal precaution, it's fine. Ignore it. Don't panic. Don't take stress. Okay. So I enter the room, introduce myself to the examiner. Now I said, verbalize what I'm seeing. I can see my patient is attached to the monitor. There is another question. Can I see, because some academies say, I see the patient, you are talking, some people talk to the patient and say, I can see you are attached to the monitor. Usually we don't say that to the patient, okay? I can see some question coming, but after this part, I will take questions. So if you have a question, you can drop it in the chat box, but I will answer all your questions, okay? Don't worry. Talk to the patient. So you will talk to the patient saying, hello, I'm Dr. Basant, I'm one of the doctors here. Don't say, I'm one of the doctor in the department, because like make it simple. I'm one of the doctors here. Some people make it a bit complicated. I can't remember what they say, but make it simple. Could you confirm your name and date of birth? If you find a date of birth, you will confirm a date of birth. If you find age, please confirm age. Is that okay? So when you go, you will find three situations. Either the patient is talking, he's answering you, at least talking, confirming his name and age. You can find the patient mumbling. Mumbling means like doing, you know, this is the sound of mumbling. He's not really talking. Or you find the patient unconscious or unresponsive, okay? Or the patient will be talking, and you are ignoring something, and the patient become unresponsive. So I need you to expect what you're gonna see, okay? Talking, mumbling, unconscious, okay? Or unresponsive, okay? So now you imagined how the simman look like, what you will find in the room, how you will be assessed. You now know what is the situation you're gonna face, okay? Now you know when you read the sim what you need to focus on. Now you know when you enter the room what are you gonna do initially. Your name, your GMC number, looking around. I can see my patient is attached to the monitor. I assume I've taken all universal precautions. Hello, I'm Dr. Basant, I'm one of the doctors here. Could you confirm your name and date of birth? Or if you remember his name, Adam Smith, right? Can you confirm your date of birth? Okay. One of the most common mistakes that a lot of candidates do, that they tell the patient, how can I help you? Already in simman, you have a very long stem. Some people will get confused because of the information there. So paraphrase. I understand that you have shortness of breath. I understand that you have leg pain. I understand that you're feeling dizzy. I understand that you vomit blood. Make it, save your time, please. You don't have time to ask, how can I help you, and ask a specific question. Okay, could you tell me more about that? Golden minute, important to give open-ended question. Tell me more about what is going on, and then go from there, okay? If patient able to talk, take brief history. Analysis of main complaint, differential diagnosis 1 or 2, medication, medical condition, medication, allergy, smoking, alcohol. One of you will ask me a question, is smoking alcohol and alcohol important in simman? I think it's a waste of time. Why it's important? What do you think? Why smoking and alcohol is important in simman station? In COPD, amazing. In hypoglycemia, brilliant, because of alcohol, because we have hypoglycemia with alcohol overdose, like alcohol intake. What else? Oxygen, good. What else? In blood, in vomit, I don't know, explain to me more. Alcohol toxicity, okay. Why? What else? What else? Hematemesis. Yeah, hematemesis, alcohol is very important question. What else? What else? Okay, what else? MI. We have angina case. Exactly. What else? So smoking is very important. What else? Drug overdose. It's not really related. Like alcohol, not really. COPD, yes. What else? we have atrial fibrillation. Alcohol and smoking can increase it. Also can cause arrhythmias, like you feel your heart rate. Also, in case of heart failure, you need to know if there any a history of heart problems, and heart problem can be related to smoking and alcohol. So all what you said is amazing in bleeding, in COPD, because if we are offering the oxygen, so smoking and alcohol is important. But in some situation, you will not need it. So I wrote down here, plus or minus. Why I wrote that here? Because it's not important in each stage. So you will think for a while, is that important to me? And then you will go from there, okay? Okay, in each station, I will tell you what kind of analysis of my complaint you're gonna do, exactly, like to the point. What kind of differential you're gonna make, like 1 or 2, and it depends on each station. I will tell you medical condition and what is important, medication, allergy. Allergy is important because you're gonna take some medication. You give the patient some medication, and family history sometime, smoking and alcohol. Sometimes we will deal with another situation, like for example, like postpartum hemorrhage. The question will be a bit different, but this is like generally, okay? And by the way, if you today get out of this lecture just knowing that what is the simman look like, what is the ABCD generally, your concept about simman is like clear, more clear, this will be enough for me. Because in tomorrow and the day after tomorrow, for the next 5 days in the course, we will repeat ABCDE in each station, and we'll talk about what is important, what is not important. We'll talk about that many times. Just I need you to have an idea. Don't take stress. Take it with like relaxed mind. If you take the information with a relaxed mind, it will keep in your mind for longer time, okay? So anyone has any question till now, before we go to ABCDE? If you have any question, write it down in the chat box. There was a question from Noreen. Do we need to, may I proceed after saying GMC number? Okay, so do I need to say, may I proceed? Okay. I need you to think about 2 things, okay? The first thing, and this is a good question, by the way, because I keep telling the people the same. Will that add something to you? No, it will not add something to you, okay? So if you said your name and GMC number and go on, no one will blame you, okay? No one will take your marks, because you just confirm and then you go, okay? The second thing you need to consider regarding this question, will the examiner answer me? Some examiner will not. Will I take stress if he is not answering? He might answer and might take time to answer. He might in the beginning not expecting this question. He might ask you again, what you mean? So if it's not important and it will not get me any benefit, and the examiner might not answer me, ignore it. This is my answer for this question. Okay. Will we be able to watch the session on our own time if it's recorded? No, you can't. It's a kind of respect. I'm sorry, it's recorded. It's live simman course, and this is the first day. So we will continue. This is free one. If you need to continue the course, send me a message. It's a kind of respect to proceed. I need you to go to the exam and do that kind of respect, and you will see kind of irrespect from the examiner, because some of them will take time to answer or not answering, or so don't put your situation. I passed the 15 station. I never say may I proceed. Okay, I know a lot of candidates pass a lot of 16 station even, and they didn't say may I proceed. So ignore it. This is my answer. Okay. Any more questions? Okay. So what is the approach? It's A, B, C, D, E. A is airway, B, breathing, C, circulation, D, disability, E, exposure. Why is it in this order? What comes first. So how to say that to the patient? Don't say to the patient in a medical term. Say, I can see my patient, I will do ABCD assessment. It's a kind of head-to-toe examination. So when you go to the patient, explain what is ABCD, because they don't know, even the medical doctor don't know what is. So you need to explain. It's a kind of head-to-toe examination, okay? And to find out what is going on with you, to help you with your shortness of breath, to help you with whatever. So explain in a kind way. Fine. This is one of the most common mistakes, that people go and say, I will do ABCD assessment. A is blah, blah, blah. B is, if you are talking to the patient, explain it. Okay. It's kind of head-to-toe examination. Okay. So the airway is the opening of the station. If you manage it well, you will be absolutely fine. Okay. In the airway, you will see the patient talking when you go, okay? So if the patient is talking, so the airway is patent, okay? So you will need to confirm patient identity. Can you confirm your age, your date of birth, or whatever, and take brief history. So the first scenario, you go to the simman and you find the simman is talking. What are you gonna do? Confirm patient identity and take brief history if you can. If the patient is a bit struggling with talking, okay, go ABCD and then take history in the middle, okay? So in the A, in this situation, I will say, as my patient is talking, the airway is patent. Some people will say, I will say, as you are talking, your airway is patent. The patient can't understand what is airway, okay? They will not understand what is airway. So say it as if you are verbalizing to the examiner, or just you are saying your thoughts. So as my patient is talking, the airway is patent, okay? The second situation, the patient or the simman might be mumbling, might be unresponsive. So what are you gonna do with this? First of all, especially with these two, you need to confirm patient identity. What is usually missed is, if the patient is not talking, you can't confirm patient identity, isn't it? By like verbally. People miss it. No, you can confirm by looking to the bracelet. Okay. So what if, and this happened, I can't find the bracelet? What I should do? How can I confirm? What do you think?
It could be near the bed, maybe.
Near the bed.
notes.
This is a good answer. What else? What is if it's not near the bed?
Sorry, I didn't get the question, doctor.
Sorry?
No, I didn't get the question, sorry.
The question is, how can you confirm the patient identity if there is no bracelet in the patient's hand?
Notes.
If it's no, if
we
you looked
can
around,
ask
you can.
the examiner for the patient notes, can we?
Okay. Okay. Ask the examiner. Examiner will not answer you. So you will tell the examiner, I want to confirm the patient identity. Okay, you look for the legs and you can't find. There is someone saying this. You looked around for the notes, you didn't find. What you should do?
We will just proceed.
Okay, this is a good point, but before that, you will say something. I will ask the nurse to bring the patient notes to confirm the patient identity. Okay, I will ask the nurse or ask my colleague to check the patient notes and to confirm the patient identity. Okay, you need to say, and then you will proceed. One of the things that I want to keep in your mind, the examiner will not respond to you. Because if you are expecting this, you will be like more relaxed in the exam. You are not expecting anything. So low expectation, more happiness, okay, in life generally. So don't expect anything from the exam. Okay, so I will call for help. And if I'm calling for help, and this is important thing, I'm working in UK. So we usually, they for any doctor working in UK, they do some like training on a simman. Do you know why they give us simman? For two things. To see that you are working in a team. This is the first thing. The second thing, to see, to put you in difficult situation and see how you react. If you are not working in a team in a cooperative way, you fail the simman. If you are not acting well with the simman, you fail the simman. So this is out of my, like I got teached simman, and I'm teaching neonatal life support also simman. So both of them, what we are looking for, team working and how to manage according to your job. By the way, in UK, you need to know that before you come to UK. There are steps, like you are FY2, you are allowed to do 1, 2, 3, 4, for example, okay? 4 points. For example, you are very experienced person. So you, for example, can intubate. If you do that, you are breaking the system. Why? They have system. Why? Because you are competent, but other people can do the same, they are not competent. Or can cause harm. So there are steps. Even you are experienced, you should follow 1, 2, 3, 4, okay? So you should know your limits as FY2. Is FY2 able to deal with a patient mumbling, unresponsive alone? No. So please don't forget to call for help. And if you are not doing this, you are not safe. You don't know your limitation, okay? So you will call for help. If the patient is unresponsive, I will just put unresponsive. This is unresponsive, you will do BLS. What is BLS? Basic life support. How to deal with a patient who is unresponsive. First of all, you need to check this patient is breathing. Don't go and look and deal like he's mumbling. No, mumbling means like he's alive. But for unresponsive, you need to check, is this patient breathing? So what are you gonna do? You will tap on the shoulder. Like for example, Adam, can you hear me? And you are tapping on the shoulder. And you will check if the patient is breathing or not. I will check the patient is breathing or not. You will do, to check breathing, you will open the airway, okay? How I will open the airway? I'll do head tilt, chin lift. Can you see this? This is the one. So, like if the patient is lying, the tongue get down here and obstructs the airway. Here, if you are doing head tilt, chin lift, so with your left hand over the head and your right hand, it doesn't matter if you are left-handed or right-handed, okay? And right hand under the chin, and you elevate the chin. This is head tilt, chin lift. What happened here? Can you see this obstruction? It will be open. This will become open. Okay, so this is head tilt, chin lift. So what I do with that, I open the airway, so it will allow the patient to breathe. Okay. So let's go back. So again, I know this is the beginning, and you need to be fully absorbing what you're gonna do in this. If you manage this step, especially if it's unresponsive or mumbling, you will find it easier later on, okay? This is the most thing I need you to focus, because it gives you in the exam the courage to continue, okay? So talking, I will confirm the patient identity. I take brief history. As my patient is talking, the airway is patent. If the patient is mumbling, like or unresponsive at all. Adam Smith, he's not answering. So what you're gonna do? First of all, I will confirm the patient identity by looking to the bracelet, okay? So if I can't find the bracelet, I will look for the notes. If I can't find the note, I will ask one of the nurses to confirm the patient identity and to bring the notes. I will call for help. And if the patient is unresponsive, before you call for help and do BLS, how you can do that? Tap on the shoulder and check the breathing. The patient is breathing. I will check the airway for foreign body and foreign body and any secretions, because this thing can block the airway. And you will open the airway by head tilted chin left. Secure the airway by nasal or oropharyngeal. Let's go here. What is that? What is that? I can see you're asking question. I will finish the airway first and then answer your question. But answer me, what is that? What do you think? Because you need to get that out of the tray. It's oropharyngeal. Amazing. So is there any contraindication for oropharyngeal?
Semi-conscious.
In semi-conscious, why?
Gag reflex.
Gag reflex. In semi-conscious patient or unconscious and become conscious or like semi-conscious, it will cause gag reflex. Okay? Okay. What is that? What is that?
Nasopharyngeal.
Nasopharyngeal. So this one, do you know when it's contraindicated? When I can't use?
Fracture.
Skull base fracture. If there is a fracture in the skull base, if I insert this, it can cause some problems to the brain and brain stem and so on. So I can do it in the skull base fracture, but I can do in everything else. So do we have a case of skull base fracture? No. So if you bring this out of the tray, out of the trolley, and you use it for the patient, put it beside the patient, it will be amazing because you don't have a skull base fracture till now, okay? So I know some people of you are not really in news with this stuff. So let me explain to you something. This is soft, okay? So remember, soft, getting into nose, which is soft, okay? This is hard if you hold it, it's hard, and it is hard palate, okay, going into the mouth, okay? So this is oropharyngeal and this is nasopharyngeal, okay? Both of them, what they can do, look here. This is nasal cannula and this is nasopharyngeal and this is oropharyngeal. Both of nasal and oropharyngeal, they reach here. So they can maintain the airway and the patient can, if spontaneously his breathing, can get the oxygen in, okay? So they open, sorry. They open the airway and maintain the airway open, and so the oxygen and air can get in, okay? So now you know how the oropharyngeal look like. It's hard, and there are different color with different size. Whatever you find in the trolley, you will get it output beside the patient. You know how is the nasopharyngeal look like, okay? So it's a soft to soft, which is nose, nasopharyngeal. You will get outside. If I have both, use the nasopharyngeal because 100% it will be fine till now in the exam because we don't have skull base fracture. This is how to do head tilted chin lift. You should do by yourself. One hand will be on the head, push it back, and one on the right hand on the chin, lifting it, okay? This is head, tilt, chin lift. This is nasopharyngeal, oropharyngeal, how they open the airway, okay? Okay. So what I did, patient is mumbling. I will confirm the patient identity by looking to the patient bracelet. There is no bracelet. I will look to the notes. So there is no notes. I will ask one of the nurses to bring the notes and to confirm the patient identity. I will open the airway. I will call for help, and I will open the airway, do head tilted, chin left. I will look for any foreign body while I'm doing this. Like while I'm opening the airway, I will look here. So I'm doing this, I will look here to see if any foreign body. And I will secure the airway by nasopharyngeal or oropharyngeal. Nasopharyngeal is contraindicated in skull base fracture. Oropharyngeal is contraindicated in, it's not absolute contraindication because you can insert a smaller one, it will not cause gag reflex. So oropharyngeal can be also okay. Nasopharyngeal only contraindication indicated in skull base fracture. So the next step is, if I'm not securing the airway, if the airway is at risk, okay? So now I have airway at risk, which is not open, okay? So I need to take further step, which is intubation. To do intubation, is FY2 able to do intubation? Yes or no? Is FY2 is able to do intubation? Is if he is experienced, do you think FY2 can do intubation? Yes, no. What else? No, 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 yes, okay. No. Okay, the answer is no. As FY2, you are not allowed. We call the anesthesia doctor, which the specialist one, not SHO. We call that specialist, the registrar, to do intubation. Okay, it's not an FY2 doctor to do intubation. So that's why you call for help, because you might need an anesthesia doctor to come. So how we can decide that this patient need intubation? By doing something called Glasgow Coma Scale. Glasgow Coma Scale is a bit complicated one. You will assess movement and eye and verbal. There is another one which is a bit simple, a bit better, which called ABCDE score. Alert. This patient is alert, responding to voice, but not like alert. Like if you talk to him, he will respond. Respond to pain, unresponsive. This is the equal degree in GSC, GCS in ABCDE score. Again. We need to assess Glasgow Coma Scale, because if it's 8 or below, we will intubate in this score. We will talk this score in disability here, okay? We will talk it in details how to make it, okay? But I will not discuss this now. I'll discuss this later, because I need you to make it easier for yourself. And what you need to do is to do ABCDE score. This patient is alert and talking, fine. And I will not do it here, because if the patient is talking, I will move here, isn't it? So it's not one of the options. Is the patient responding to voice? Like if I'm saying Adam, and he's saying, yeah, doctor. So he's responding to voice. So he will take 13. If 13 need intubation?
No.
No. So for the pain, if the patient is not responding to the voice, Adam Smith, not responding. So I will do pain. How to induce pain for the patient? Please be gentle, please, because I know there are a lot of doctors like in causing pain, they will hit the simman very hard. Please, it's very expensive. And I know if you are doing a favor for other candidates to destroy it, it's okay, fine. But you can pinch the finger, okay? gently and nicely. I will pinch your finger and you will see the response. Maybe he moves, maybe he do something, maybe he withdraw his hand, maybe he say something with the pain, like or like become a bit alert, more alert. So if he's responding to the pain, equal 8. Do I need to intubate if the patient is equal 8?
Yes.
8 or below, intubate. Okay. So I will consider it. At least I will consider it. I will call the anesthesia. If unresponsive, I can give the patient, it depends, like it's 6 or below. So I will give in this, so what I need to say, in these two, this pain and unresponsive, I will consider intubation. So according to ABCDE score, my patient is alert, my patient is responding to voice, the patient responding to pain, the patient is unresponsive. So if the pain or unresponsive, I will call anesthesia doctor to come to consider intubation. Okay, I have now your question. The first question, how can I call for help? I can say I will call for help, or I can say I will activate code blue. I will activate 2222. This is the code for help. Okay, 2222, or activate code blue, or I will call for help. All of them are fine. Okay. There is another question. Should I do head tilt chin lift by myself? Yes, you need to. It's super easy, and the simman is moving. You can do it. Okay. So there is another question. Should I do it in the D part? Because why I need to do AVBU score or Glasgow Coma scale here? Because I need to know, is the patient needing intubation or not? Because all of them will be like, if this, like generally, if you're going to someone and he is not responding, okay? So it can be, he might respond to voice, he might respond to pain, he might be unresponsive, you don't know, okay? So you need to know, because intubation is kind of airway management, okay? Okay, there is another point. Someone told me, because I will be confused, can I say I will call for anesthesia doctor anyway? Yeah, you can say, but it's not the best way. It's not, this is, make it as the last thing. You forget something, or you feel like, okay, I'm confused now, or a mistake has done, you have been going, like you did a mistake in the exam, and you say, I will call the anesthesia to consider intubation if the patient needs. It's not the right thing to be done, but if you forget, I have no option, okay, you can say it. Okay. So any other question? Do we have to, Hannah Nasser, do we need, do we have to put nasopharyngeal airway in the nose, or just put near the simman? Put near the simman. You don't have to insert it. Okay. Okay. So I will repeat that again, and I will ask one of you to do the talking, and one will do mumbling and or unresponsive. Okay. So please revise with me again. If I'm going to the simman station, I will knock the door. I will say my name, my GMC number. I will look around. I can see my patient is attached to the monitor. I assume I've taken all universal precautions. Hello, I'm Dr. Basant. I'm one of the doctors working here. Adam Smith, right? Could you confirm your age, please? 50. Okay. Then I will see if the patient is talking. So I will confirm patient identity, and I will take brief history. Fine. If the patient is mumbling or unresponsive, I will confirm the patient identity by looking to the bracelet. I can't find the bracelet. I will look for the note to confirm the patient identity. I looked around, I can't find the note. I will ask one of the nurses, ask one of my colleagues to come and check the notes and confirm the patient identity. Okay. Okay, so I will call for help. If unresponsive, I will check if the patient breathing. I'll tap the shoulder. Adam Smith, check breathing. I'll do head tilt, chin lift, look in the airway for any foreign body, any secretions. I will insert a nasopharyngeal or oropharyngeal accordingly. You will open, by the way, you can say I will secure the airway by nasal or oropharyngeal and look what is there, okay? Sometimes you can find oropharyngeal, sometimes you can find nasopharyngeal, sometimes you can find both. So choose whatever and put it besides the patient. And Adam Smith, I'm checking AVBU. Adam Smith, he's not responding. I will pinch your finger, Adam Smith. He's not responding. Adam Smith. So he's not responding to according to AVBU score. So I will call the anesthesia doctor to consider intubation for this patient. Okay. So Mayada is asking a very like good question. Thank you for asking this. Usually I don't get into this question unless I come tomorrow in most common mistakes and talk more about it. AVBU score in mumbling patient also. So generally I'm giving you the general idea. There are some details we will talk in most common mistakes in revision in each station. So I need you to know how to handle generally. So in mumbling, sometimes the patient is mumbling because of pain, but he talks. Do we need to do? No, it's talking. Patient is talking means airway is patent, but she is in pain. So is doing, MS. And sometimes she is talking and all of a sudden not talking, just mumbling. So you need to open the airway, but don't check for full body intoxication because the patient was already talking, okay? So mumbling point of view is a bit like tricky. Is the patient mumbling but talking, or just mumbling, or was talking and just become mumbling? So you got me, Mayada. It's a bit, this thing I took up, there is only station which is purely mumbling, okay? Which is hospital-acquired pneumonia. Other mumbling with talking in other stations. So I will tell you talking and mumbling, fine. But just mumbling, no. I need to follow the mumbling one, okay? So there is, should I say the patient scores out loud? Yes. You need to verbalize everything. So you need to say patient is alert regarding AVBU score. Patient is responding to voice in AVBU score. Patient is responding to pain. Patient is unresponsive. I need to do the next step. Hypoglycemia is unresponsive, so we need to mention intubation. Yes, I have a question to you. Is that secured patent airway in hypoglycemia unresponsive? Is that secured? Do you know what is going on in hypoglycemia? Just unresponsive patient. You don't know really, you're not really sure, maybe a new station, maybe. You don't know really what is going on. So yeah, I will consider intubation. Intubation will not happen in 1 second because another team will come and they will assess before they do, and then they will intubate. Okay, and in hypoglycemia, I'll give you a trick you need to do. In everything will be fine, okay? Like the monitor will be amazing, the patient chest will be fine. Go quickly, and in C-bar, don't wait to D-bar, because in reality, I worked in ENA. If the patient unresponsive, is the patient seizuring, we will having seizure, I mean, we will check glucose early, like in C, okay? We will maintain the airway, do the breathing part, and check glucose in C. It's one of the vitals. So in hypoglycemia, the trick is I will tell to you in the revision and in the hypoglycemia station, do the glucose in C. Don't wait, okay? Do with the blood because it's kind of vitals, by the way. So secure airway, ask for intubation, do the B part, do the glucose level in C. Okay. So I need one of you to raise hand, please, to simulate with me.
Okay, person.
Imran. Imran, is that Imran?
Aladdin.
Aladdin. Okay, so give me a second. First, I need to set the time for you. So, I have to. So you will have 30 seconds, okay, to read the stem and to start, okay? So I will give you 30 seconds. I know it's a bit quick, but okay.
Hello,
Hello.
I'm Dr. Kamel, one of the doctors here in the medical unit. Are you Emma Smith?
Yeah, doctor.
Could you please confirm your age for me, Emma?
60, doctor.
So, okay, thank you so much. So, could you please tell me, Emma, what happened with you?
Well, doctor, I've been admitted here for the last few days for waterworks infection, and I'm not feeling well at the moment.
Oh, I'm so sorry to hear that. I will help you in a minute. What's your feeling right now?
I'm not feeling well, doctor.
Okay, Emma. Okay, I will check you. I will do proceed like ABCD approach to check on your vitals. Okay, so since my patient is talking, I assume that the airway is patent. I move to B. I'll check your chest now, Emma.
Amazing, amazing. But what we said about the station, Francis, we said my name, my GMC number, and verbalize for me, looking around. You don't need to in the exam to see look around, but I need you to imagine it that you're doing. I'm looking around. I can see my patient is attached to the monitor. I assume I've taken all universal precaution. Hello, I'm Ala, I'm one of the doctors, and so on. So where is the beginning? Where is the beginning part?
Yeah.
Yeah, this is a part. And if the patient is talking and stable, take more history. You're not in a hurry. She's not well. What do you mean by feeling unwell? Can you explain that more to me? What about, and take one or two differential, medical condition, medication, allergy, and if it's relevant, smoking, alcohol. Alcohol will not be here very like needed, but you can ask about smoking. Again, we will repeat again, okay?
Okay.
Give
Hello?
me a second. Give me a second. I will set the timer again.
Hello, I'm Dr. Kamel, GMC number 795592. Hello,
Hello.
I'm Dr. Kamel, one of the doctors here in the unit. Are you Emma Smith?
Yeah, I'm Emma Smith.
Yeah. Okay, before that, I will look around and I will verbalize, assuming that I'm putting the universal precautions. I can see that my patient is attached to the monitor. Hello,
Hello.
are you Emma Smith?
Yeah.
Could you please confirm your age for me, Emma?
Doctor, I'm 60.
Okay, Emma, could you please tell me what happened?
Doctor, I'm not feeling well. Can you help me, please?
Sure, Emma, I will help you right away, but could you please tell me in which terms you're not feeling well? Can you please tell me?
Doctor, please help me.
Okay, Emma, I'm here to help you, Emma. Could you tell me, are you feeling any pain?
No, doctor, it's no pain, but I feel like I can't take my breath.
I'm so sorry
Please
to
help
hear that.
me.
Okay, Emma, I will help you right away. Okay. Are you having any medical condition, Emma?
Patient can talk. Do you think patient can talk?
No,
At that
no.
moment, the patient can talk. So look to the monitor and manage. The patient is talking his airways. I played with you, but don't go with me. Okay.
Okay.
So now I am struggling with, I'm talking, but I'm struggling. Don't take history, right? This is the point. So if the patient is talking, but if like comfortable, take history. If patient is struggling, I can't talk, I can't breathe, I'm not okay, please help me. Doctor, I'm drowsy, I keep annoying you. Stop the history. Look to the, start ABCD. Okay?
Okay.
Let's start again. So, again, focus with
Hello.
me. No. So,
Okay.
my name, you have a pen and paper.
Yeah.
You have a pen and paper.
I have.
Yeah, my name, my GMC number. I can see my patient is attached to the monitor. I assume I've taken all universal precautions. Hello, I'm Dr. blah, blah, blah. I'm one of the doctor working here. Can I confirm name and date of birth? So after that, you will see if the patient is talking, I will take history, and comfortable, I'll take history. And I will assume airway is patent. If talking but struggling, the airway is patent, but I need to move to B, okay? So if the baby, the patient is mumbling, I will do these things that we talked about. Call for help, check the bracelet, call for help, open the airway, secure the airway, and EVBU score. So I can do any scenario of this. I need you to act on different scenario. And this is the beginning. If you master the beginning, it gives you the push, the courage to continue the simman. You will feel good in the exam. Okay, that's why I stop here for a while, because if you feel down or like you feel annoyed in the beginning, you will feel like you will disturb. This will disturb your mood in the exam. I need your mood to be good, not in stress. So we will keep practicing till you make it. Okay? Do you need some time, Dr. Kamal?
Yeah.
Okay, fine.
Okay.
Give me a second. Okay, you can start.
Hello, my name is Dr. Kamel. My GMC number 79559192. I can see that my patient is attached to the monitor, assuming that I'm wearing universal precautions. Hello?
Hello?
Are you Emma Smith?
Yeah.
Sorry. I'm Dr. Kamel, one of the doctors here in the unit. Could you please confirm your age for me?
60.
Okay, Emma, thank you so much. So, Emma, could you please tell me what happened with you?
Doctor, I was admitted here for the last few days for waterborne infection, and since morning I'm not feeling well.
I'm so sorry to hear that, Emma. Could you please tell me more about it?
I feel like I can't take my breath very well. I feel a bit dizzy. I don't know what is going on with me.
Okay, do you feel any chest pain?
No, at the moment.
Only shortness of breath, right?
Exactly.
Since morning?
Since morning.
Okay, and you mentioned also you are feeling dizzy?
Yeah, I'm a bit dizzy.
Okay, Emma. I will help you in a minute. Emma, do you have any medical condition apart from the waterworks infection?
No, no at all.
Are you allergic to any medicine?
No.
Okay, are you taking any medication?
No, doctor.
Okay, Emma. So you are here in the hospital for the last few days, right?
Yeah. So amazing. So you will take history and then you will move to B, okay? Amazing. So as my patient is talking, I will follow ABCD assessment to find out what is going on. As my patient is talking, the airway is patent, I'll move to B, okay? So the other thing, we need another candidate. Thank you, Dr. Kamil or Kamal.
Thank you so much. Thank you.
Another candidate, can someone raise hand or like write in the group or open mic? Reem, Dr. Reem, open your mic.
Yeah. Hello.
Hello. So you will have the same scenario, okay?
Right.
But I will give you different situation, okay? Do you want some time to read the stem again?
Okay, sure. Where is it? Can you just repeat it?
You need, okay, so you need this.
Yeah. I just want to make sure.
So what is the question you need to ask yourself while you're reading the stem? What's the question?
What's the patient complaining of? Like, how
Okay.
can I help her?
No. What is the question you need to ask yourself while you're reading the stem? I think you missed the first in the beginning, isn't it?
Maybe, yeah.
I mean, where I am.
Oh, yeah, okay. Where I am and what station this is? Like, you told us we can know, like, if it's simman or not.
Okay, what about the third question?
I don't remember actually.
So where I am?
Okay.
What is the patient name and age?
Okay.
Should I talk to the examiner or not?
Okay.
This is the questions, okay? So start again. Ask yourself these questions while you're reading the stem.
Okay. Emma Smith, 60 years old. I'm in the medical unit. I'm gonna talk to the patient. Verbalize. Yeah, and the 2 minutes I will talk to the examiner. I should talk to the examiner.
Enter the room, start.
Okay.
Start.
My name is Rina Badal. I'm one of the doctors here. My GMC number is whatever. I noticed that my patient's oxygen is actually low. It's 73 right now. So I'm going to provide them with oxygen first before I start the procedure. I just need to identify the patient first. But before anything, I noticed that because they're on the connected to the monitor, I'm taking all the universal precautions. Now I'm identifying the patient. Hello, this is Emma. Can you speak to me? This is Emma. Okay, I tapped her shoulder.
No
This is
response.
Emma. No response, right? Okay, I'm going to do the head tilt, head and chin tilt to check for anything in the area. Is there anything? Do I find anything?
No, you can see.
Okay, yeah. Okay. I'm going to look at the bracelet.
Sorry?
Is there a bracelet?
A
Hello?
bracelet.
Yeah, yeah.
Yeah, you can see the bracelet and confirming the patient identity.
Okay. Is there any way to find out if the patient has COPD or something before I start or no?
No, sir, no, sir, here, not here.
So I'm just going to bring an oxygen mask and connect it. So high flow oxygen.
So you will fail this station. Do you know why?
Why?
Do you know why?
Why?
Because you are moving to B and you are ignoring the part of A that you need to open the airway, secure the airway, call for help because this patient is not talking. If you are moving to B and the airway is closed, this patient is gonna die before you treat him.
Okay, so I did the head tilt, but I should have secured the airway first.
Secure, call for
Okay.
help, secure the airway, and open the airway by head tiltation left, secure the airway by nasopharyngeal, call anesthesia doctor, because like AVBU score, what is your AVBU score?
Yeah, the patient was not responding to anything.
Exactly.
And
Did you bench her finger? No, you
not
didn't
yet,
assess.
not yet.
You didn't assess. So if you are not assessing, you will fail this stage. And then you will come to say, I failed simman. This is not fair exam. I don't know why I failed simman.
Okay, I have a question.
Yeah.
Here in this case, the oxygen is very low and it's decreasing. So I should still do all of those other steps before giving oxygen?
Yes, because you need to do ABCD. Okay, you need to secure the airway. Maybe because this is because the tongue is compressing there is a lot of noise around you.
Mhm. I'm sorry because I'm in the hospital. I'm
Okay,
going to mute
so
myself while you're talking.
okay, thank you. So what I'm saying is sometimes the tongue is making compression on the airway. So if you are not solving this, if you just solve it, maybe it's solved. Okay, so sometimes there are secretions, there is foreign bodies, there is a swelling in the mouth, in the tongue, causing this low saturation. That's why it's ABCD. That's why I focus and I stop to make sure that you get a part right, because if you get it right, everything will be fine, because the other point are fine. This is the most tricky part in the simman. If you are not managing it well, you will not get it. You know what I mean? So what I'm saying is check A first. So if don't look to the monitor, don't look to the word. When you go to the station, my name, my GMC number, look around. I can see my patient is attached to the monitor. I assume I've taken all universal precaution. I will talk to the patient, okay? After that, you will Emma Smith, talk to the patient. And then you will assess A first of all. She is talking, this is, I'm assessing the airways patent. She is not talking or mumbling, so the airway problem here. So I'm assessing the A in the beginning. Don't go to B, don't treat B, don't treat oxygen. You are not treating the monitor. You are treating the patient. So monitor is my guide. It can be my friend, okay, but it's not the patient. So because the oxygen saturation can be low in airway obstruction, in an anaphylaxis, it's not related to the B now, it's related to airway is closed. Patient unconscious because the airway at risk. So the saturation, don't treat monitor, okay? So go with A, then B, then C, and so on. Is that clear, guys? Is that clear?
Yes.
Yeah. Anyone has any question? Is that not clear for anyone? Okay, I will assure you regarding something. This A will be repeated again and again and again in each station. You will masterize it. I know it's a bit tricky. If you just get the idea, general idea, I will be happy. Okay, because we will repeat everything again. Tomorrow in the beginning of the lecture, in the second day of the course, I will repeat all of that again. I will remind you again and again. so don't worry, okay?
Hello.
Can Dr. Can you give me a second? Dr. Reem, can you do it again? Can we revise it again?
Yes, please.
I will revise it with you again.
Okay. You can hear me, right?
Yeah, I hear you well.
Oh.
So my name, my GMC number, I can see my patient is attached to the monitor. I assume I've taken all invasive precaution. Hello, I'm Dr. Basant. I'm one of the doctors. Can you confirm your name and date of birth? Patient is talking, so and confirm the patient identity. I will take brief history if able to. If it's not, I will go to B part, okay? If the patient is not able to talk, mumbling or unresponsive, I will confirm the patient identity by looking to the bracelet. I will call for help. If unresponsive, I will tap the shoulder and do the check the breathing. I will open the airway by head tilted chin left. I will check for any foreign body or secretion. I'll secure the airway by nasopharyngeal or oropharyngeal. I will do AVBU score. Emma, voice not responding. I will pinch your finger. Emma, not responding. So his patient is unresponsive regarding AVBU score. So I will call the anesthesia doctor to consider intubation.
Just a second. So we're going to put in the nasopharyngeal tube before doing the ABPU, right?
Yeah, because this is the securing the airway. This is like adjunct or like it's kind of tools that opens the airway until intubation, which is more advanced step to be done. Clear. So you can do it again, okay? Yeah. Can you raise your voice, Reem? I know because there's some noise around.
Okay. Is this better? Is this better?
Yeah, much better.
Okay.
So where is yeah, start. Start.
Okay.
Sorry.
Morning.
Where's the practice one? Okay, good morning.
I'm Reem Ghorab, one of the doctors here. My GMC number is 123. Are you missing Emma Smith?
Yeah, I'm Emma Smith.
All right. How are you?
Doctor, I'm not feeling well.
Can you tell me what the problem is exactly?
Doctor, please help me.
Okay. Just how can I help you? What is your? Do you feel pain, or is there a problem with your chest? What
I
exactly?
can't take my breath, doctor. Please help me.
Okay. So the patient is talking. The airway is patent. Okay. However, okay, now the same problem. The oxygen is low.
Exactly.
Okay.
This is the thing. Amazing. You did it. So A, patient is talking, airway is patent, and move to B. But before that, say, I will follow ABCDE assessment to find out what is going on with you. Okay? It's kind of head to toe examination. So as my patient is talking, the airway is patent, I'll move to B, the breathing part. I can look to the monitor. I will talk about B. Okay?
All right. Okay.
Okay. So I need a third doctor to practice with me, and it will be the last one. Manu?
Manar.
Sorry?
Manar.
Mana. You hear me?
Yes, you can hear me 100%.
Yeah, this is the step. Start. When you're ready, let me know.
Okay. Okay.
So what are the questions you need to ask to yourself?
Where am I? I'm in emergency department. Who's the patient? I'm 60 years old. Do I need to talk to the examiner? Yes, I need to talk to him. I told it.
Okay, start.
Okay. Hello, Manar Lamy, my GMC number 1234. I can see that my patient is attached to the monitor, and I've assumed I'm taking all the precaution, universal precaution. Hello, I'm Dr. Lam with the doctor here. Are you Emma? Are you Emma Smith?
Mm,
Well, I can see that my I'm gonna tap on the patient's shoulder. Emma, do you hear me? My patient is mumbling. She's not responsive, so I'll check, confirm the identity by checking the bracelet. Now I'll check the
confirm it.
airway.
You found it.
Okay. Now I'll check the airway by doing a head tilt, chin lift, and I'll call for help and secure the airway by nasopharyngeal tube. Okay. And now I can see that the I'll go to the B part and give
No, what is
oxygen.
missed? What is missed before B part?
I did the airway. I said I'll do head tilt chin lift and do nasopharyngeal tube, call for help.
Okay. What?
do GCA? APB?
AVBU. Yeah, exactly.
APB, okay.
Yeah, do it.
Mhm. Okay. And now I'll do assessment for my patient following the ABPU score. She's unresponsive, and nonverbal. So I'm going to check the pain response by pinching her finger.
Patient mumbling.
Okay, patient is responsive to pain, and I forget the score. I'm not sure about that, but I'll call for the anesthesia and to consider intubation.
Oh, okay. To consider intubation. This is amazing. You did very, very well. That's why it's a bit stressing. It's a bit challenging. If you keep practicing on this, and we will practice in each station, so you will do well in the exam, because you are you feel stressed, isn't it? You feel like, I don't know what to do. This will happen in the exam. If you are not preparing your mind to these situations, you will not do it in the exam. So we need to practice this many times till we master it. Okay, so tomorrow we will practice on this again in the beginning of the session, and we will like one or two will do again, whatever we will finish, like maybe B, C, whatever we finish. Okay, so give me, where is, yeah, so we finished the A part. Okay, let me answer your question first. How do we introduce? We'll talk about that, B part. Do we need to intubate even though the patient responds to pain? Yeah, we need to intubate because it's 8. We will consider intubation. We'll call anesthesia team. Be considered only when the patient is totally, no, we can, yeah, let's go to this point. If the patient is in pain, this means this is 8, which means we will consider intubation. We will call the anesthesia team to come to review the patient. Unresponsive mean on GCS 6, which will need intubation. Both of them need intubation. Well, if the patient is doing more, oh my goodness. Sorry. If the patient is making like a strong reflex to the pain, it can be responsive to pain. If he's doing a bit, the patient will not move. Okay, and if it's not verbally saying, anyway, we will consider intubation. Okay, but if the patient is doing more reaction regarding the pain, we can say it's a response to pain, okay? Any other question? If the patient is unresponsive, it is better to do jaw thrust or head tilt chin lift. Hamna, Nasir, if the patient is unresponsive, we will do head tilt chin lift. When we will do jaw thrust in head trauma or like accident, which is not the case in plateau, and head tilt, you can't do jaw thrust besides the patient. Jaw thrust need to be done while you're standing behind and you can't access. So what are you gonna do is head tilt chin lift in all the station which need opening of the airway. Clear? Let's go. Let's move to so again, what you get? Imagining the situation that you will paraphrase instead of saying how can I help, how to take history, what is A and what is the situation you will find in A. I need to tell you something, and it will be more in revision. I will tell you that in airway, you can find lip swelling and tongue swelling. You can notice this in the simman. They can make swelling in the lips and tongue. If you notice this, equal anaphylaxis, okay? So once anaphylaxis, what you're gonna do, you will stop the source of anaphylaxis, which is blood or antibiotic, and you will give adrenaline, and we will talk about that. So what kind of findings that you can find, really you can find, is lip swelling, tongue swelling. Once you've noticed this, it's anaphylaxis. If you miss it, I will tell you in the anaphylaxis case and in the B part what you're gonna do, okay? And you need to get the nasal or oropharyngeal out of the tray and put it beside the patient. I will tell you tomorrow how you're gonna deal with the trays, the drawers, and how it will be arranged. This is in the most common mistakes, okay? It will be tomorrow. So after you finish A, either you secure the airway by nasopharyngeal and call for intubation, or you patient is talking and you take history and you assume the airway is patent and you move to B. So in B part, you will first look to the monitor, and there is a common mistake here. Can you look to this? A lot of numbers here, isn't it? Can you mute yourself, please? Can everyone mute himself? So there are a lot of numbers here. So heart rate, I need you to focus sometimes in the exam with the stress. So heart rate will be 87. So some people will consider it oxygen saturation, and sometimes oxygen saturation is 77, for example. So this will be, some people will consider it heart rate. Please, when you are looking to the monitor, one of the common mistakes that you confuse between what are you seeing. So please take a second to focus. While you are looking to the monitor, take a moment to focus what you are seeing, because yeah, I know you have the right to feel confused about it, but you need to, this is heart rate, this is oxygen saturation, this is blood pressure, this is respiratory rate. You see this respiratory rate very small down, like below the monitor. You find temperature in the monitor. So please take time and think about it. What I am seeing here, don't be in rush, because if you are treating or you're observing something which is not true, and you are treating or dealing the patient in this way, you're gonna fail it, and you will fail it because of concentration. It's not about your knowledge, because you're not concentrating. So now you know this is a mistake. What you should do, you should know this is mistake I need to avoid. No, temperature is not on this one, I'm sorry. It's not here, but in the exam, it will be on the monitor, okay? Tomorrow session is free, no? tomorrow session will not be free. It's in the course. If you are interested in the course, please give me a message. I will tell you this is New Year offer. It should be £40 per person. If you are like per person, like alone, it will be £30. If you are group of 3, you can collect a group of 3 for £20. Okay, you have access to the course twice, this time and the next time, and you will have access for simulation video for each station, like a real station. I will share one of the simulation videos with you on the group. If you have the group, so if someone doesn't have the group, I'll share the group with you again. I will share a simulation video like the one that you will get. So you will like it's like in the exam. I'm doing the simulation by myself. Okay. Could you please repeat the price again? If you are normally it's £40 for the New Year offer, it will be £30 per person. If you are group of 3, it will be £20 per person in the group of 3. Okay. I think I sent the group. This is a group link. If you want to, no, I'm sorry, I'm sending to Reem. I sent to everyone. I'm the admin of the group, so no, I'm sorry. I will not. This will not be recorded, and you will not be able to get the record in the course because it will be live. I need you to attend. It can't be recorded. And I'll make another one in few days, so you can attend with the same payment. So I need you to attend live. No, I need everyone in the course to practice. If you are not practicing, you are not gaining it, because you will listen to the A part and you will feel like, oh, it's amazing, it's fine, I know it. And once you practice it, you will feel like, what the shit is this? So you need to attend by yourself, practice by yourself. Okay. Okay, let's go for B part. Okay, do you have any question?
Dr. Person, I have one question regarding head tilt chin lift. Do we like do it or verbalize it?
You will do it.
Mm-hmm.
Okay, let's go for the B part. How you will manage the B part? First of all, you will look to the monitor, and I told you there is a mistake which is very common, which is people will look to the monitor, but they will not concentrate what I'm saying. So they will consider heart rate as oxygen saturation or vice versa or whatever. So please look to the monitor, concentrate well, and go from there. Oxygen saturation normally should be 94% or more. Okay. In each step, I will tell you what is the normal, what is the abnormal. Okay. And if the abnormal, I will tell you when you will find this abnormal and how to manage it. Okay. So the normal is 94. Below this, it's low. I need to do something. Okay. And respiratory rate normal from 12 to 16. Okay. If the respiratory rate is lower than 12, if respiratory rate lower than 12, this means morphine overdose. You don't have any station, you will find the respiratory rate like 8. So once you find respiratory rate is low, means I'm talking about morphine overdose. Okay? Respiratory rate high, more than 16, in a lot of situations. So there is not a specific, in just shortness of breath, in heart failure, in pain. So respiratory can be high, but when it's low, it means morphine overdose. Okay, so if oxygen is low, I need to give oxygen before I examine. Okay, so how can I offer oxygen? Before offering any oxygen if you don't ask, do you have smoking? Do you smoke or have smoker cough? Do you have COPD? What is a smoker cough? Is the lay word of COPD, okay? So do you have COPD? Do you have a smoker cough? So if the patient, it depends on the patient answer. The patient can answer you, no, I don't have COPD, I don't have a smoker cough. If you don't ask this question and the patient is COPD, you're gonna kill the patient and the simman will die and you will be in very bad situation. Ask this question to avoid fatal mistake. When I say there is a fatal mistake here, please write it down, document it. I need to ask this question. Sometimes I'll tell you, if you miss something, miss it, okay, but you can't miss this question. Some situation I will tell you, you will avoid inspection, palpation, percussion, and you will go for auscultation because you need to speed up. Sometimes I'll tell you, no, stop here and ask this question, do this thing. So when I say do it, it's fatal. You can't ignore it, okay? If you miss it, for example, I told you if you miss, I assume I've taken all the investor precaution. If you miss it, it's okay. Here, if you miss it, return back and ask about it. So do you have COPD? Do you have a smoker cough? No. So I will provide the patient, and oxygen is low. I will provide, by low, I mean it's, let me write it down again, less than 94%. So if oxygen is low and patient is not known COPD or smoker cough, so I will offer oxygen via non-replacer mask. I know that some of you are not in the medical field, okay? So, or like not seeing this before. So this is non-replacer mask, okay? Have to know it. It's a kind of empty bag, like a bag here, white bag, or let me delete that so you can see. And here, this is connected directly. See, there is nothing here. So what is this? Non-replacer mask. When I offer it for the patient who has no COPD, no smoker cough. So how many liters of oxygen? I will give 10 to 15 liter oxygen, which will provide the patient till 95%. And when I'm giving the patient the oxygen, I will tell him, it should help you with breathing. I will give you oxygen. It should help you with breathing. Is that okay? If the patient is talking, please, this is your IPS. So again, I check the monitor. So I will move to breathing part. I will check to the monitor. I can see oxygen saturation is low and respiratory rate is normal. Can you see temperature here? This is between me and you, wink, wink, and I will tell you why we need to do that. I'm not writing in black, I'm writing in blue because this is something I will tell you why I put temperature here. Don't verbalize it, I will tell you why I put it here. So please, someone is opening his mic and making noise. Mute all. So, do you hear me? Oxygen is low, and ask the patient, do you have COPD or smoker cough? I know there is a question coming to your mind, Can I ask, do you smoke? It's not about smoking. Sometimes patients are smoking, but they don't have COPD. Sometimes the patients are not smoking and have COPD because some people, if is there someone from Pakistan here? Anyone from Pakistan? Yes, Sumpal. From where is Sumpal? From where in Pakistan? Lahore. I visit Peshawar and I visit Islamabad. And I've seen a lot of patients, and Zahid from Lahore. Nice to see you guys. I visit Peshawar and Islamabad. A lot of pollution. And I feel there is a lot of patients, because of this pollution, they're getting COPD. So it doesn't mean that COPD equals smoking. COPD can be a lot of things from smoking, okay? So I need to ask specific. Do you have COPD or smoker cough? Okay. COPD is a smoker cough. It is the same. This is the lay language. This is a medical term. Okay. Ask in that way. Do you have COPD, smoker cough? No. I will give the patient oxygen via non-breather mask. Sometimes the examiner will ask you how many liters. You can say 15 liters. What is the oxygen you're gonna give? 95%. So 15 liters via non-rebreather mask. The oxygen I'm gonna give from the non-rebreather mask is 95%. I will say to the patient, I will give you oxygen. It should help you with breathing. Okay? Okay. So what if the patient has COPD or smoker cough? So I found that the oxygen is low. I can see your oxygen is low. And do you have COPD or smoker cough? Yes. So in this point, what is the target? My target for oxygen is 88 to 92. Please, this is a very important point. Why I can't raise oxygen to 94 or more than 92? Because I will say it once, so please concentrate. Why I can't give high oxygen? Because in our body, CO2, carbon dioxide, is the trigger for the respiratory center to work. There is a specific limit in our body. It stimulates the center. If I give more oxygen for the COPD, this patient used to high CO2 in the body. Their body containing high CO2. If I giving them high oxygen, this means CO2 will get out. When the CO2 get out of the body, this means that this patient has no trigger for breathing. The CO2 will not activate the breathing center. Then the patient will stop breathing. So it will cause breathing depression, respiratory depression. So I can't give, so this is for your knowledge. You doesn't need to know that. If you didn't get it, ignore it. So you don't need to give high oxygen. What you need to do is to make sure the target is 88 and to 92. So how can I give oxygen for a patient with COPD? So normally, the oxygen in the air, in the normal air is, what is the percent? What is the percentage of oxygen in the air? 21. Well done. It's a 21. So can you see this? What do you see here? This is a blue. I will not make that. This is a blue adapter that in something called Venturi mask. When I insert this adapter here, this gives me specific amount of oxygen. Can you see this? This is 24%. So it's a bit higher than the oxygen in air. It gives 40 liters per minute, okay? And this one, this is a white one, a white removable adapter. This gives 28%, 4 liters. What about the orange? Give 31%. So I'm giving a specific amount, limited amount of oxygen to make the target is 88 to 92. Okay? You agree with me? So if I want to give the patient with COPD oxygen, I will give via Venturi mask. Venturi mask containing different adapters. I will choose which one in the beginning. I will choose which one. I will choose the blue. Why? Because it is the least amount of oxygen I can give to the patient to make sure I'm not giving him more oxygen. Because if I give more oxygen, this means that patient will not breathe by himself, will cause respiratory depression. So I will try the least. If it's working, it's okay, amazing. If it's not working, I will give the white. So there is a question will come to your mind. So should I memorize all the colors? No, you don't have to. Just you will try the blue and you will know the white. Know these two, the blue and white. Blue first and then white. Easy. The examiner might ask you, how many liters? So you'll start by 4 liters, which will give the patient 24%. I will tell you something. If you look to this, from this side, if you look from this base, there is a number, the concentration number of the concentration of oxygen gonna be given to the patient is written on it. For example, in the exam, I got confused which color I need to do. I need to give. Look to it, it's written. It's better not to waste time on this. So it's a blue and white, but in the exam, if you, okay, lost, you don't know what to do, look to it, it's written on it, okay? Give how much oxygen. So you will choose the blue. I zoom in, I can't zoom in, unfortunately, but I can see if I can do that. Can you see better now? So it is here, okay? Is that what you want to see? Okay, so I return back. Tick, 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 tick. Okay, so this what is called, it's a removable adapter. It's different colors, different concentration of oxygen that gonna be given to the patient. I start with the least, which is the blue, and then the white. That's what I need, okay? So what this one? What is the nasal cannula? When I need the nasal cannula in upper GI bleeding, okay? But may I ask you why? Why I need the nasal cannula in upper GI bleeding? By mean upper GI bleeding, vomiting blood. Because can you imagine? I put this mask like I put this mask, the non-rebreather mask, and the patient vomit. So he and then after you vomit, you take deep breaths. This is the normal. You vomit and then and in this the deep breath, the patient aspirate. In the vomiting that he vomit. If you put non-rebreather mask or Venturi mask in the exam, the patient will arrest. Again, if you put Venturi mask or non-rebreather mask on the face of upper GI bleeding, the patient will collapse. The patient will arrest. The patient vitally will go down and the patient arrest, and you will be in a bad situation. When I say it's important, write it down. It's one of the things, if you did, the patient is arrested. So you need to take care of this. You can mess with anything, but you can't mess with this. Because if it's arrested, you maybe a lot of candidates, their mood become changed if they did badly in one station, especially with very stressful situation like this, okay? So they destroy the exam. They destroy all the stations. They get out of it. They get out of the mood. Please don't do that. So when I say it's fatal, write it down. This is fatal. I need to take care. I need to revise before the exam. I need to revise in the night of the exam. The nasal cannula, the COPD question. This is important. Okay? Let's have a look. How is the nasal cannula? Can you see this? There are two openings, like two tubes inserted in the nose, like here, I insert, and I will make it behind the ears, and this can be controllable. Do I need to do that? Just to put in the nose and leave the rest, okay? You need to put on the patient face. You need to put on the patient face. You need to put on the patient face, okay? There is another thing you might find in the exam. There are different types of Venturi. There is, can you see this tube? Sometimes it's not there, just the adapter. So can be like a tube there and like this, and you change the color from here, or it can be just with the adapter directly. Okay, there are different shapes. So how you will know? You will see the color. There is a question will come to your mind: should I insert the adapter by myself to the Venturi? No, you don't have to if it's inserted. If someone before you is amazing and brilliant and did that for you, maybe you're bad luck, you're the first one coming to this station, you need to insert, or it's not inserted at all. It's in the drawer, in the trolley, and you need to take both of them and put it beside the patient. Never ever say something without getting the thing from the drawer to put beside. For example, I said I will give the patient non-breathal mask, and I didn't get the non-breathal mask out of the drawers or the trolley. You will not see any improvement, and you will stuck. Okay. So again, I will check the breathing part. I will look to the monitor. I see the oxygen saturation is, respiratory rate is, temperature between me and you, don't verbalize. I will tell you why, okay? If the oxygen is low, which is lower than 94, it depends, by the way, it can be lower than 98, but for the exam, we'll consider it 94. So I will give the patient oxygen. Do you have COPD or smoker cough? There is a question coming here. What if the patient is mumbling or unresponsive and I don't know if he has COPD or smoker cough? What should do? Look to the note, check the note, ask the nurse. There is no notes. Give Venturi mask just in case. If the oxygen saturation, I say, like for example, is 80%. So it's lower than the target, Venturi and everything. Start with the least and increase gradually. Secure airway. Anyways, we secured the airway before, but we moved to B, but we found the oxygen 80%. So I asked this question to one of the consultants who is offering us simman station. And he said, if you don't know, give high flow oxygen and ask the nurses to check the nose for you. But because you need at least to reach the patient to 92 at least. So give oxygen 15 liters per minute and you can adjust, because you can't leave the patient in 80%. It can cause brain damage or below this. So if you don't know, give non-breathal mask till you know. If the patient is in septic, so he will die from this part. So you need to give oxygen till you maintain at least 294. So till 92, okay? So give non-breathal mask. If the patient is unwell, if you don't know what is this, you will treat as normal, because you will consider it's normal until proof otherwise, okay? Okay. So we know what is this? Non-breathal mask. What is this? Venturi mask. What is this? Nasal cannula. The only case I need to nasal cannula for is upper GI bleeding. I have a question. This nasal cannula can provide 24% to 44%, and Venturi mask provide 24 to 60%, right? Can I give nasal cannula instead of Venturi mask for COPD? What do you think? Again, the question again. This is Venturi mask providing 24% to 60%, right? Here, In upper GI, in the, sorry, nasal cannula, it provides 24 to 44. Can I give nasal cannula to COPD patient to offer oxygen because it's the same concentration? Why not? No, no, no. Nasal is non-adjustable. No, you can adjust. You can give 1 liter and it will give you 24%. Yes, yes, yes. No, no, no. What do you think? No, no. The answer is yes, I can. Yes, I can. If I provide 1 liter, it will give the patient 24%. If I provide 1 liter, and I will use this information later in COPD, and I will tell you when, okay? So in case of COPD, I will tell you when you will use the nasal cannula and when you will use the venturi mask, okay? It will be in the COPD, but can I use? Yes, you can. Okay. So we finished the oxygen. I found the oxygen is low. I asked the question, do you have COPD? Do you have a smoker cough? If no, I'll give non-rebreather mask. Dr. Aladdin said COPD with upper GI bleeding. Unfortunately, we don't have such a case, but I will tell you in COPD, okay? So non-rebreather mask is 15 liters per minute. A non-rebreather mask. If yes, he has COPD, I can give him 2 mask. I will insert the blue adapter. If not improving, I can change the blue adapter to white adapter. There is another way I can give nasal cannula in case of upper GI bleeding. If you didn't do that, and see how many times I said, and every time I explain the same, and in the exam, someone comes to me and tell me I give nasal cannula, I give a non-rebreather mask and the patient died. I feel like I want to kill myself instead of the simman, because I said it 100 times and I said it's fatal and I focused on it. I know it's a bit stressful in the exam, but please, when I say it's important, write it down, please. Okay, so we will move to respiratory rate. So I found the oxygen is low. I treat. Did I examine here? No, I didn't. I just give oxygen when the oxygen is low. I asked just one question: do you have COPD or smoker cough? Did I examine? No. Check monitor, oxygen, treat, check respiratory rate. Respiratory rate only low in morphine toxicity. This is the point that you keep in mind. I will tell you also in C. If you find this, mean this. If you find this, you mean this. So you need to take like point about each station. So I know the exam can't be, you don't need to be scripted, but between me and you, it's scripted because you have a specific situations, specific scenarios, and you go to the exam, isn't it? So also simman can be a bit, and I'm sorry to say that, a bit scripted in such a situation, like morphine low, patient unresponsive, patient mumbling without talking. You found the blood transfusion, you found rash, you found the swelling, you find catheter, you find inhaler in the drawers. There are a specific situation you should notice and deal, and at least you know in which station you are. So do you after doing the oxygen, now respiratory rate in examination, if you don't take permission from the same man will shout at you and you will be in a bad situation. Take permission before you expose the patient, and please be gentle. Like, don't uncover forcefully, like gently uncover, okay? I know with the stress, we are stressed, but tell the patient, I need to examine you. I need to examine your chest to look, listen, feel, and tap, and maintain your privacy. I'll have a chipper with me. Is that okay? So, for example, this is in every station. I have one candidate who went to the exam, and he said to the patient that And he uncovers the patient without saying. He said in the beginning, I will examine different parts in your body and I will have children. Is that okay? Patient said okay. But when he exposed his chest or his private part, patient start shouting. You can't do that, even if you take permission. So, for example, you went to a doctor and this give you, this means a permission for this doctor to examine you, isn't it? And all of a sudden, the doctor expose your chest. How you will feel? It's inappropriate. He can't do that. Even you go there by your leg, by yourself, by your decision to be examined. But it doesn't mean that you are allowed to unexpose without saying. So please remember this. So in examination part, so take permission. I'd like to uncover you. So there are different things. Some people will say, I don't say uncover, say I will expose. Don't say expose, say unbutton your shirt. It doesn't matter, okay? Uncover is nice, it's fine. If you say expose, it's fine. But it's uncover, it's more like lovely way, it's okay. So don't stop at this point and make argue for nothing, okay? You can say I will uncover you. There is inspection, palpation, percussion, auscultation, okay? By inspection, once you see red spot on the chest, equal anaphylaxis, equal stop the blood or antibiotic, equal give adrenaline 0.5 milligram 1 to 1,000 intramuscular in the thigh. See this what I said, every single detail I said now, it's important. 0.5 adrenaline. 1 to 1,000. You will find different medication. You need to choose 1 to 1,000, not 100, not 1 to 1 to 10,000. You need to choose a specific 1 to 1,000. Intramuscular in the thigh. This is important. One of the candidates gives adrenaline IV. Patient arrested. He verbalized IV. Patient arrested. One of the candidates gives the patient muscular in the bottom. I don't know why. And he injected. You don't have to inject it. Just take it and put it beside the patient. Don't give IV. Okay. So inspection, rash, anaphylaxis. Palpation. You will not find anything in the palpation in the B part. Okay. I see you are exhausted, isn't it? Why not we do circulation now? I think 3 hours today will be fine, and we can take circulation the next time if this is the thing that you are saying. So inspection, rash. If you able to, we can take circulation tomorrow. If you want to, we will see later, okay? So palpation, percussion, auscultation. In palpation, you need to see that trachea is central. Okay? Is that important? No, it's not important. So when I say it's not important, it means if you know yourself is slow, you need to speed up. Okay? You need to ignore some steps. For example, you know you are dealing with case of acute limb ischemia. Okay? There is no need to check the chest in each detail, percussion 15 times, 16 times, 50 times percussion. Be quick. You need to know when you speed up, when you slow down. Okay? So, palpation, sometimes you need to do quick. Sometimes you need to ignore. By the way, no one do palpation unless you are suspecting a trauma, or like you will check trachea central and you feel by your hand and do percussion. No one doing percussion in E&E, by the way, but like you can verbalize. I can do palpation, percussion, and you will hold the stethoscope and listen. You can verbalize without doing. Don't take half an hour in percussion. It doesn't make any sense. So you need to know when you need to speed up, when you need to slow down and stop for some point. Okay, so In auscultation, okay? Give me a second, okay? You can listen to, as I told you, you will have to put the stethoscope and listen by yourself on the chest of mannequin, right? So you will hear normal sound of the chest, or can you tell me what kind of sounds that you will hear now? Okay, give me a second. So I need you to listen to this and write down in the chat box, what kind of sound is this? What do you think? Wheezes, amazing. This is wheezing. Once you hear wheezes, there is a step to be taken. You need to put an nebulizer and give salbutamol. Amazing, you are amazing. All of you said wheezes, okay? So what is this? This is wheezy chest. How do you know? You need to listen to this. I will put this in the group so you can listen to what is the wheezy chest again and again. If you don't know, I know some of you are not like in the practical part. So you need to listen to this one more times, like to know. Wheezes is expiratory, like you feel fine, but while like very harsh sound, okay? So the inspiration itself is fine, while the expiration you will hear the wheezy sound. So I will put on the group, please listen to it if you don't know it, because it's important, you need to know to do it. So once you find your wheezy chest, you need to give, if you are giving oxygen, you will change to nebulizer mask. How the nebulizer mask look like? Can you see this? Can you see this part? This kind of like a tube, there is a cap. This is rolling or rotating, and you will open it by rotating, vice versa, and you will put the salbutamol or whatever the medication you're gonna give, and you'll close it and you give it to the patient. And the vibrations coming from here, it's the air coming from here will make vibration here, okay? And the patient will take. So what you need to do in the exam, you will change the mask, bring salbutamol and put beside the patient, and put the mask on the patient's face and choose the right mask, okay? Let me clean all of this so you can see the mask again. And you need to give this normally, if non-COPD, the normal patient without COPD, you will give it driven by oxygen, and you need to repeat salbutamol every 20 minutes if needed, okay? Clear? So once I found wheezes, I take an action, okay? So you don't have to put the nebulizer inside put the salbutamol or medication inside, just bring out from the trolley and put it beside the patient and says, I found salbutamol, I put in the nebulizer, and I'll give the patient 5 milligram of salbutamol in the mask. Okay? Okay, so the second question, what is this sound? What is this sound? You hear it, guys, crepitation, crackles, crackles, crepitation, crepitation. crepitation. This sound is crackles. So let's get to the point. What is the difference between crackles and crepitation? So I will keep you listen to crepitation so you know the difference, okay? Give me a second, okay? It's a bit tricky, isn't it? This is crepitation. It's a bit tricky, isn't it? So I will tell you how to avoid such a mistake in the exam, okay? So first of all, let me give you the knowledge, okay? And then I will tell you how to differentiate in the exam. Crackles is kind of coarse sound, and crepitation is fine sound, okay? I will put both sounds on the group in both links so you can listen to it. So crackles is a bit coarse, crepitation is a bit fine. When we can listen to crackles? In which situation I will hear crackles? It can be in a lot of situations, but in the exam, in which station? In infection, amazing. And when I can listen to crepitation? Crepitation in heart failure, amazing, amazing, brilliant. So crackles in chest infection. In the exam-wise, because we can listen crackles to a lot of things and crepitation for a lot of things, and crepitation for heart failure. But will I, in the exam, be able to? No, you will not. So this one thing, me, myself, get confused in the exam. And it's a bit tricky. If it's infection, you need to give fluids. If you give fluid to heart failure, you will kill the patient. So what I should do? That's why I told you here, look to the temperature. And this is between me and you, and don't verbalize it. Because if you find the crackles or crepitation and you can differentiate, look to the monitor. If there is high temperature, means infection. If temperature normal, mean heart failure. This is a kind of a scripted thing, and this is between me and you. Don't say that to anyone, okay? Because it's a bit tricky. If it's an infection, you need to give, and sepsis, you need to give fluids. It's part of sepsis protocol. And if you give fluids in heart failure, you will kill the patient, okay? Okay. So initially, I will tell you salbutamol. There is a lot of protocols, salbutamol, and then salbutamol, and then salbutamol ipratropium, and then a lot of things according to the station. Take from me now, I heard wheezes, so I changed the mask to nebulizer mask, give salbutamol, driven by oxygen, and I will repeat every 20 minutes. So in COPD, should I give driven by oxygen? I will say that in COPD, but I want you to know the general. There is a question, how you will give the examiner will ask you, how you will give the salbutamol, driven by air. How driven by air? What do you mean driven by air? This is a question will be asked by the examiner. What do you mean driven by air? No, not through nasal cannula. Yeah, it's, how can you give nebulizer through nasal cannula? It will be nebulizer mask, but how can you give by air without oxygen? How without oxygen? This is a question. I will answer this question in COPD, okay? Okay. Then you will do ABG and chest X-ray, okay? There is a point. Let's get to this point. Auscultation can be normal. You can hear crackles or crepitation, How to differentiate between them? Look to the temperature. This is between me and you. Don't say it. Look to the temperature. If you find temperature high, so it's infection, I can hear crackles over the chest. If temperature normal, I can hear crepitation. Okay? And for the wheezes, for crackles and crepitation, no need for immediate action. But I know now there are some fluids or some problem. I will do further action accordingly. If it's crackles, I will do further action in C. If it's crepitation, I will do further action in C. But at the moment, no action in P. Clear? This is important. Do you want me to repeat? Clear. Okay. So wheezes, I will take immediate action, which is nebulizer. Nebulizer, the initial thing, 5 milligrams salbutamol. If you're giving oxygen already, it changes with nebulizer. If you are not giving oxygen, which is not the case, you will give nebulizer. You know how nebulizer mask lock? You need to search about salbutamol. Sometimes I will say that in the most common mistake, how the medication in the drawers, how to find it, how it looks like in the drawers. I will say that in most common mistakes tomorrow, inshallah. You need to ask for ABG and chest X-ray. Okay, there is a question here. Someone will ask me, should I do ABG and chest X-ray in each station? Even the B part is fine? This is a question. What is your answer? No need? No, yes. Who else? I need everyone, you need to answer. No. What's the question? Okay. Should I do ABG and chest X-ray in each station, even the breathing part is fine? Risk of unnecessary radiation, yes, no. Okay. I will answer this question. The question is, ideally, no, you don't have to. Okay? If everything in the breathing part is fine, but for the exam purpose, which I need you to have the approach to fix it. Initially, yes, do for every station because it's unwell. If you request it, there is no harm. Unwell, I need to know. Maybe lung cancer, maybe anything else. Okay, maybe ABG is I can check for other things in the ABG itself, like glucose, like electrolyte, like pH, like bicarb, like CO2. So normally in the real life we don't, but I need this for the exam purpose because I don't want you to miss this. So I want it in your approach. At the end, when you are very calm in the exam and you can manage it, you can skip it, yes. But for now, I will not allow anyone who is practicing to skip it because I need it in your approach. I need it in you. If you say it, it will not, because like a big problem if you say it. If you miss it in some situation, it will be critical. Okay? Okay, I take it back. Yes. Okay, Dr. Ala. So to recap, first of all, I check the monitor. If any abnormality, I will treat. If the respiratory rate is low, means morphine. If oxygen low, I have 3 options. I will ask first, do you have COPD or smoke or cough? No. So I will give 15 liter oxygen by non-rebreather mask. If has, I will give Venturi mask. I will choose which color? Blue, and then white. Nasal cannula when? In upper GI bleeding, fatal mistake. I showed you what is the non-rebreather, what is the 2 types of Venturi. I showed you nasal cannula. You should be able to pick from the drawer and give it to the patient, put it on the face of the patient. Then, what is the nebulizer, how it looks like. And if you are listening, if you see rash, equal anaphylaxis. If you listen to wheezes, equal immediate action. If you hear crackles and crepitation, look to the monitor. See temperature, heart failure, or pneumonia. If you hear crackles or crepitation, verbalize it, and no immediate action in B, you will take action in C. Okay? Ask for ABG and chest X-ray. So if you find rash, do you remember? I told you I will talk about that in details in anaphylaxis. Someone is asking me repeat anaphylaxis part. In the rash part here, you will find, oops. So you will, in the rash part on the chest, you will find the spots there are like a plaster. It's transparent plaster. I will show you, I will draw it for you. It's transparent plaster, okay? They will bring a marker, red marker, and they will put it on the plaster, and they put the plaster somewhere in the chest. So this means there is rash. They are making like a rash. So if you see rash, the only case you can see rash on the chest is anaphylaxis. So I will say, but I will talk about that, how to say it in everything and how to handle it. Do you remember? I told you before in A, it should be in A. Lip swelling, tongue swelling, it's anaphylaxis, do action. Here, if you find rash, anaphylaxis, do action. I'm giving you the signs that you can take care of in anaphylaxis. Don't delay. If you delay adrenaline, the patient will die. Put it in arrest simman, okay? So you know when the simman is arrested, so you to avoid it, okay? So this is a rash. This is a finding you can find. Palpation, percussion, sometimes you need to speed up, just you can verbalize and move. Auscultation, we talk about that. Sorry, we were answering the question. What to do if respiratory rate is low? No, it's morphine. I will say that in morphine station. If respiratory rate is low, it is morphine toxicity. Do we need to give or do immediately? Yes, you need to. And I will tell you in morphine when you need to give naloxone. You can give in A part, and you can give in B part in this situation, respiratory rate is low, and you can give in D part. So the more intelligent you are, more smart, more if you are good observer, most likely you will save this patient. If you delay it till D part, this patient might stop talking, and when you stop talking, you will start again from A part, and then you will be in trouble. So being good observer, and I will give you some trick for the morphine part, okay? So, no, simman rest, the arrest simman, I will talk about that in most common mistake, how to deal with the simman if the simman arrested. I will take that tomorrow. So I need someone to practice with me breathing. Who will? Raise hand, please. Ruwa Subhi. Can you open your mic? You can't. I'm sorry. I will do that. What is the name again? Ruwa Subhi. Ask to unmute, or what I should do?
Hello, Doctor.
Yeah. Okay. So practice. Okay. So you are going to this station, and you will start from B part. So you will say, I will start breathing B part. So what you gonna do, okay?
Okay.
So you have the stem. This is the same stem we practiced before on. And this is your monitor. Give me a second to adjust it. Blood pressure. No, we will not play with it. Okay, start. B part. Start from the B part.
So now I'll be checking the B part in ABCD protocol. I can find that breathing, the oxygen saturation is 86%. If I go for, the patient was either the conscious one or the unconscious, or
Patient, will it matter?
yes, if the airway is secured and the saturation
Yeah,
is low.
we have already done the airway. Airway is now secured, patent, or like she's talking. It doesn't matter in P part now because we already secured it and manage it.
Okay. So now we will need to if the patient is talking, I will ask if she has a smoker's cough.
I'm talking. Okay, I'm talking.
Okay.
Yeah.
I can see that your oxygen is a bit low. Do you have COPD or smoker's cough?
No, doctor.
Okay, then I will help you with some oxygen via non-rebreather mask. It will give you oxygen in 10 to 15 liters per minute. It should help you with the breathing a little bit.
Okay.
Okay. After that, I will go for chest examination and check the respiratory rate. It's not written in the
No, it's written
it's 10.
down.
It's 10. It's 10. Respiratory rate is a bit low, so this is okay. Respiratory rate is fine. So we'll go to examination. I will do inspection if there is any rash.
No rash.
Okay, I'll do superficial palpation quickly on all quadrants and percussion, and I'll try to auscultate.
Auscultation. You hear. Give me a second. You hear the sound. No, give me a second. Sorry.
Take your time.
Stop.
No, the sound. What you're looking for?
It's either crackles or crepitation, mostly crackles.
So what you're looking for?
The temperature.
Temperature, it will be written on the monitor in the exam. So I will tell you temperature is normal, 37.3.
So I'll be thinking of heart failure. So then I will be
This
moving.
is between me and you, don't say it,
Yeah.
okay?
Yes.
Okay.
So for me now the chest part is over, and I will
Okay.
go to check the circulation afterwards.
Okay, there is some points you missed.
Okay.
First of all, I'd like to check your chest. May I uncover you to look, listen, feel, and tap? I'll maintain your privacy. I'll have a chip with me. Is that okay?
Yes.
This is the permission. If you don't do it, the patient will shout at you. The second
Sure.
thing. Chest X-ray and EPG.
Okay.
Okay?
Okay.
Okay. So, another doctor.
Thank you.
Thank you. Farah, can you open your mic? Are you able to? The B part is fine. I know it's easy. The most difficult one is the A part. That's why I'm telling you, I stop in A part for a long time and I keep repeating it because I know if you manage, I will do Farah. If you are not managing A part well, you will get confused. So if you're managing A part well, you will go from there and you will have the courage to do it. Farah. Yeah.
Hello?
Hello. Start from the B part.
Okay. So I can see if the patient is responsive or not. So I can ask them whether they are
Yeah, responsive.
responsive. Do you have COPD or smoker cough?
No. Start from, I will move to the B part, which is breathing
Okay.
part. I will look to the monitor and so on.
Okay, I will start with the B part. I will look at the monitor. Looks like your oxygen sat is getting low, and your heart rate is going up. Can you hear me?
Yeah, I hear you, doctor.
Okay. Do you have any COPD or smoker cough?
Yeah, I have COPD.
Okay, I will be able to help you with that. Just a minute. I will put Venturi mask, the blue adapter.
Okay.
How are you feeling now?
A bit better, doctor, a bit better.
Okay. Are you okay? Your respiratory rate is high and your SAT is getting better. Okay, I'd like to examine your chest. Actually, it's your saturations aren't ideal, so I think I'm gonna add the white adapter. Okay. They are getting better now. Are you with me?
Yeah, doctor.
Okay. Are you feeling better now?
Yeah, a little bit better.
Okay, great. I'd like to examine your chest to look, feel, and tap, so I will need to uncover you if that's fine.
Okay.
Okay. Thank you. I want to
Doctor,
look.
Doctor, are you harassing me?
Sorry?
Where is the children? In
Oh,
UK,
okay.
if you are not offering a children, the next day this patient will go and you will go to court because he will raise a complaint that you are harassing him, and no one
Okay.
has seen that.
Okay. Okay, I'd like to examine you if that's okay. I'm gonna ask for a chaperone just to ensure your privacy. I will want to uncover your chest if that's okay.
Okay.
Okay, I want to look for any rashes. Are there any?
No.
Okay, I want to palpate for the trachea, it's central. And I'd like to auscultate. Okay, well, Mr. It seemed like your chest is a little bit wheezy. Do you have okay, so I will change the mask and I would put the nebulizer mask, 5 milligrams salbutamol.
Driven by?
Oxygen? Is it he has COPD? I'm not sure. Driven by air?
What do you want, doctor?
Okay, driven by air.
Okay.
Okay, your oxygen sat is getting better. How are you feeling?
Yeah, much better, doctor. Thank you so much. You're amazing.
You're welcome. I'd like to take some bloods for your ABG, and I will also want to order an X-ray. How does that sound to you?
Okay, doctor, do whatever it takes. Amazing. One thing is, I'll maintain your privacy. I have a chip with me, don't forget.
Yeah.
And other thing is, driven by air, COPD, you can't driven by oxygen. And I will say that in details. You're right. I didn't explain too much, but I will explain COPD.
Okay.
And when you choose air, and when you choose nasal cannula, when you choose Venturi mask, when how to give the nebulizer, all of these, but I don't want to get into details because I need to just you to focus on the basic thing. The second thing is, if you offer Venturi mask blue adapter, don't change quickly. This is in common mistake. Thank you for bringing that to the session now. If you are doing changes to the mannequin, don't expect a quick reaction because the examiner will take time to change. This is the first thing. The second thing is the patient might have something else like sepsis. And if you give high oxygen, he will not improve because he has sepsis, chest infection and sepsis. So you need to give antibiotic. Sometimes in COPD, he has wheezes, he has obstruction of the airway. So he needs salbutamol and he will improve. So give blue adapter, and then move.
Okay, so move to the next step.
The respiratory rate, move to the chest examination. You will hear wheezes, you will give nebulizer. If it's not improving, I will tell you the next time. But I mean, don't keep it changing. Some people, this is one of the most common mistakes I will tell you tomorrow. Some people stuck. I need the oxygen to improve. I will not move from here until oxygen is improved. And he will get out of the station, losing the station.
Mm-hmm.
So you need to do the step, move, get back, do another thing. Don't do everything in one go, okay?
Yeah, but not move from the B, right?
No, you can move from B if there is improvement.
Okay. Mm-hmm. Thank you.
Okay. Yeah, you need to comment on everything summer. You need to comment on respiratory rate and oxygen saturation, everything, because you need to verbalize everything, even it's normal. If you listen to the chest is normal, I can appreciate normal chest sound. Okay? You did amazing, guys. So I'll see you tomorrow for the course, of course. We will talk about D part. We will talk about, C, D, and E, and most common mistakes. It will be 5 days. First day is today. Every day is 8 p.m. UK time. Apart from the last day, it will be 6 p.m. UK time. If we need 6 a day, we will do it. I need everyone to practice. So make sure you are in place that you can open your mics and keep practicing. If I need your feedback about the session on the group, if you can write your feedback, please. If someone wants to join the course, it will be a group of 3 for £20. What else? If someone needs simman mocks, please let me know. Okay? This is absolutely online. We keep practicing online. And I told you why, because online you need to have the base, you need to practice, you need to know how to do it in the beginning, and then you can practice on by the way, no real simman in the academies, as I'm aware of. So you will practice on a pillow, it's fine, on a toy. So just keep practicing. Or if someone if you are in specific academy and you want to practice, you have the knowledge, you have the basis, you have the tricks, you have the tips. So it's online. We practice online. If you want simman mocks extra, I can provide you. If you want prescription, procedure examination, the clinical part, if you need prescription correction, if you need to write every prescription and someone to correct for you, we have this service. If you want something, please let me know, because there is a lot of things. If you want the theoretical part, I mean the not clinical part, I have it. So everything you need, I have it. Okay. So if you're interested in the course, please today join it, because tomorrow I have a shift in the morning. I'll be busy. Okay, I have a GP appointment, so I'll be busy. So please let me know today. Okay. Even if you're not able to pay, okay, I can just add you and know like who's a patient, who's the people with me. Okay. If I need your feedback about the session, if anything need to improve, just let me know. And if any groups of 3, just also let me know. I can provide today with payment stuff. And all the people, you did amazing. Thank you for being with me. Thank you for staying for 3 hours listening to a very naughty doctor saying blah, blah, blah. Thank you so much. I appreciate it. A session is at least 3 hours. Every session, 3 hours. I will not take more than 3, because I feel like will be exhausting for you. So 3 hours, 3 hours, 3 hours. Whatever we finish, whenever we finish, we finish. I give all the time. I give all the effort. So I need you to masterize it. So maybe 5 days, maybe 6 days, maybe more, but I need to masterize it. Mock price. If you want to a mock, it depends. If you are inside the course or outside the course. If inside the course, the mock will be 3 station for £10. If outside the mock, 2 station for £15. Because if you are inside the course, sorry, if you're inside the course, you will make it easy on me. If you are outside, I will explain everything from the beginning. So it's so hard on me. So it depends. So that's why I'm telling you, for the mocks, just let me know. Yeah, you can message me privately on the group. I'm the group admin. I will share the group again. And of course, please invite your friend to the group. This will be amazing. And please, your feedback about the session will be highly appreciated. Thank you so much. Have a good night. Thank you for being with me. Thank you for listening. Bye-bye. This is a group link. Please invite your friends.